We want to inform our patients and not alarm them, and it's often a balancing act.
That is a lot of information about diarrhea to make sure we understand.
Yes, it is. Nurses, you can do this. Work together as a team. Buddy up with your preceptor or mentor. Don't be afraid to talk to your pharmacist, talk to your medical oncologist, and don't forget to engage your patient in education and in the assessment. Working together as a team, we can give irinotecan safely.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Rae Norrod, CNS Manager of the Oncology Services Line at Kettering Health Network in Kettering, Ohio, and member of the West Central Ohio ONS chapter, to discuss how oncology nurses can safely administer irinotecan chemotherapy and manage its associated adverse events. This episode is part of an ongoing series about outpatient oncology drug infusion. The other episodes are linked in the episode notes. Thanks for joining me today, Rae.
Oh, hi, Stephanie. Thanks for having me.
To start us off, what types of diagnosis is irinotecan used to treat?
Irinotecan is indicated for metastatic colorectal cancer. You may see it given alone or in regimens like FOLFIRI, FOXIRI, and FOLFIRINOX. It can also be used to treat metastatic esophageal or gastric cancer, lung, and pancreatic cancers.
With so many drugs, sometimes, they only have a limited number of diagnoses that they treat, but definitely irinotecan appears to have several different areas that it is effective in, which is really exciting.
Yes.
So can you talk about what the drug's mechanism of action is for us?
Irinotecan is a plant alkaloid in the camptothecin category. Basically, it works in the S phase of the cell cycle to inhibit topoisomerase 1 and cause double-strand DNA changes. Because camptothecins are cell cycle specific to the S phase, their best tumor kill is when given in frequent doses or as continuous infusions to allow the maximum number of cells to be exposed to the drug at just the right time in their cell cycle when they're vulnerable to that drug.
It's so interesting to always hear about, how these drugs actually work. So thanks for explaining that to us.
Sure.
So irinotecan has been approved as an IV infusion, like we said, since 1996. But in 2015, it was approved as a liposome injection therapy for certain indications as well. Can you help us understand what the difference is with these two different types of infusions?
So in general, liposomal formulations are not interchangeable with plain drug. Liposomes are used as a carrier, usually to control the delivery of a drug. So a liposomal drug may be distributed differently to certain tissues in the body, and it often has a longer half-life or stays in the circulation for a prolonged amount of time before it is metabolized and excreted. So liposomal irinotecan was developed mostly with the idea of how can you maximize the anti-tumor efficacy and maybe minimize some of the drug-related toxicities compared to the conventional or the non-liposomal formulation. The liposomal irinotecan is approved for metastatic adenocarcinoma of the pancreas in combination with 5-FU and leucovorin after disease progression has occurred from gemcitabine therapies. So it has a slightly different FDA indication than the plain non-liposomal irinotecan.
Well, are there any distinct factors that nurses should keep in mind for the two different medications? I mean, the same medication, but the two different formulations is the word I'm looking for.
Basically, they do have different FDA indications. The plain irinotecan is usually seen in metastatic or advanced colorectal cancers, while the liposomal irinotecan tends to be seen more with advanced pancreatic cancers. And when we administer them, the liposomal formulation we know has a longer half-life. It stays in the bloodstream or circulation much longer before it's metabolized and excreted. The uptake in certain tissues may also be altered because of those liposomes, and the drug would then maybe be distributed in some tissues more readily than in other tissues. In this case, some of the GI tract tissues, there is thought to be better uptake, or therefore getting the drug to the right tissues that are involved with cancer.
That's good to know. Thanks for explaining that a little bit more. I think for new nurses that are listening, it's just really important to understand, what those differences are. And like you mentioned, just, that half-life and knowing how long these medications stay in, our patient's systems, or where they might, as you were saying, the uptake of the different formulations might be in the body and what that looks like for their patient population.
Sure.
So, as we're talking about administering these medications, what kind of specialized training do nurses need to administer irinotecan?
Well, irinotecan is a NIOSH Group 1 hazardous drug, and so it requires safe handling precautions per OSHA guidelines. NIOSH Group 1 drugs are both cytotoxic or cell-killing, as well as having other properties. These can be hazardous to males and females who are actively trying to conceive, to women who are pregnant or may become pregnant, and women who are breastfeeding. So, according to OSHA, all personnel who may come in contact with hazardous drugs need to have safe handling education to protect themselves and others from exposures. In addition, we know that there are some best practices here. Oncology Nursing Society has a position statement about the education of the nurse who administers and cares for the individual receiving chemotherapy, targeted therapy, and immunotherapy. In that statement, ONS supports that nurses need specialized education, preparation, and training to administer and care for these patients. And then they also suggest that after the didactic class, there's a clinical practicum where the nurse can demonstrate hands-on care and have competency completion.
So you mentioned about the classification of irinotecan, and it is classified as an irritant. So what precautions do the oncology nurses need to take for medications that are irritants?
Irinotecan has been associated with thrombophlebitis. It has an acidic pH, so diluting it in at least 500 mLs of D5W is preferred, and the final concentration of the drug should be within a range of 0.12 to 2.8 milligrams per ml. Typically, then, this is given over a 90-minute period because a more rapid infusion may increase the venous irritation. In general, nurses can help reduce irritation also during the infusion by making sure they're using a large enough vein and maybe applying a warm compress at the administration site, but being sure to monitor for pain, redness, or swelling, that there is no extravasation going on, that it's just venous irritation. If for some reason extravasation would occur, even though irinotecan is just an irritant and not a vesicant agent, the RN should attempt to aspirate the drug from the IV device and surrounding tissue, and then apply a cold pack for 15 to 20 minutes at a time, 4 times a day for the first 1 or 2 days, and elevate that limb. The patient will need some instructions, especially if they're an outpatient, of what to report back, such as pain, blistering, fever, chills, and any follow-up instructions, including when to call the physician if it's getting worse.
There's so many things that we have to remember when we're administering these medications to our patients and educating the patients on side effects and things like that, which we're going to get to next. But, just that actual administration and knowing what medications are irritants or vesicants and how to educate the patient on what to let you know as, the nurse who is administering that, and to keep, an eye on or letting us know as soon as something like that happens. But also trying to, keep them calm at the same time. We don't want to, you have to balance how the information that you give, because you want them to, be comfortable getting it, but not be so anxious that they would be even more concerned or cause more anxiety during that administration. So a good point for us.
Yes, that's so true, Stephanie. We want to inform our patients and not alarm them, and it's often a balancing act.
Absolutely. So, as I mentioned, now let's talk about some of those adverse events that patients can experience from irinotecan therapy. Can you talk about those and maybe how the oncology nurse can help manage those adverse events that patients might experience?
Sure. Some of the more common side effects that we see first would be myelosuppression. Suppression of the bone marrow or low blood cell counts is common with many of our chemo drugs, and that's true for irinotecan as well. Thrombocytopenia and neutropenia do appear to be more common, so we always want to check the CBC with each treatment. Typically, if they are experiencing neutropenia or thrombocytopenia, we want to make sure the granulocytes have recovered to at least 15,000 before the next treatment, and that the platelets have recovered to at least 100,000 for the next treatment. If they haven't, the provider will be carefully deciding whether to proceed or delay the next administration for patient safety reasons. Some patients might need supportive therapies to help them with those blood counts, and those would be done per protocol or national guidelines. Another common adverse event or potential one is a hypersensitivity infusion reaction. Some patients do experience hypersensitivity during the infusion, so having a good baseline assessment that includes cardiovascular, your heart sounds, your lung sounds, and vital signs before you get started is important. It helps you notice any changes that are going on during that infusion. And of course, have your emergency equipment ready and hopefully protocols in place so that you can begin to take action. Some places have access to calling rapid response or calling a code, where others have different protocols. Again, depends on your setting. Nausea and vomiting is also quite common with irinotecan administration. Irinotecan alone has a moderate emetogenicity potential that's about anywhere from 30 to 90% likely to make the patient sick at their stomach. According to the NCCN guidelines, proper pre-medications would include dexamethasone with a 5-HT3 blocker about 30 minutes prior to the infusion. Now, if you're combining irinotecan with other drugs, you also need to consider their emetogenicity levels, and if that bumps them up to a higher category where they might need more prophylactic antiemetic. And of course, there are some patients who individually may require additional prophylaxis or breakthrough antiemetics, depending on their individual risk factors. Another common adverse event or side effect is diarrhea. And this can become dose limiting, meaning that we can't give as big a dose of irinotecan as we would like because the diarrhea is too severe for that patient, and it may require withholding the drug or dose reducing the drug due to its severity.
With the mention of these common adverse events, some of the members in the ONS communities were having a discussion about administering atropine before irinotecan to prevent some of this diarrhea and the cholinergic reactions. Can you talk about the medication and supportive options that can help to manage the diarrhea associated with irinotecan?
Oh, sure. Chemotherapy-induced diarrhea is really concerning because it could lead to dehydration, malnutrition, and severe electrolyte imbalance. And it really does also impair quality of life. For some of these patients, I just can't imagine. They feel like they're tied to the bathroom and that they can't leave the house, for example. Irinotecan also has some risk because it is indicated for colorectal cancers, and irinotecan liposomal is indicated for advanced pancreatic cancer. Both of those cancer types also have an increased risk for diarrhea to occur. In addition, older patients appear to have a greater risk to irinotecan-induced diarrhea. Overall, regimens that either contain irinotecan or 5-FU account for up to 80% of chemo-induced diarrhea, and 1/3 of all of our patients who have a grade 3 or grade 4 dose-limiting diarrhea. So whenever I think of chemo-induced diarrhea, irinotecan pops to the top of that list. I'm on high alert when I'm talking to my patient, educating my patient, as well as assessing them for side effects. Now, irinotecan can cause both an early onset and a late onset diarrhea. The early onset occurs within 24 hours of administration, sometimes even right away during the infusion. The early onset tends to be cholinergic. Cholinergic reactions develop as a result of overstimulating nicotinic and muscarinic receptors in the neuromuscular junctions. So, in addition to diarrhea, cholinergic symptoms could also include abdominal cramps, rhinitis, which is a runny nose, and increased lacrimation or excessive tearing, and increased salivation. When we administer prophylactic atropine, either IV or sub-Q, that helps reduce those secretions and prevent some of the cholinergic reactions. Now, late onset diarrhea can also happen. This would be diarrhea that appears more than 24 hours after the infusion and as late as 11 days post. This also could be dose limiting and severe. The treatment for the late onset's a little bit different, though. Loperamide is usually the drug of choice. The patient may be told to keep a box on hand at home and be given specific instructions to take a loading dose. That's often about 4 milligrams at onset of diarrhea, and continue taking it until the diarrhea has subsided for at least 12 hours straight, usually 2 milligrams every 2 hours. But your physician or your protocol may differ, so please check. But bottom line, though, I want you to know that that's not what the dosing recommendations are on the box of loperamide. So providing specific written instructions and going over those with the patient is important to make sure they're taking it as intended. There's also some non-pharmacologic interventions to help manage chemo-induced diarrhea, and these can be just as important as the drug therapy. One of the most common recommendations is the BRAT diet. This is the idea of eating more bland foods that are high in soluble fiber and pectin, like bananas, rice, white toast, turkey or skinned chicken, and mashed potatoes. Pectin actually naturally can slow down the bowel and help manage diarrhea. Of course, we want our patients to get enough fluids, but we need to talk to them about avoiding excessive caffeine, carbonated beverages, and alcohol, because those may actually make diarrhea worse. Eating foods at room temperatures may also help, because sometimes really hot foods and liquids or really cold foods and liquids can aggravate diarrhea, and having food at a more neutral or tepid temperature is well tolerated by your gut. And then, of course, don't forget pericare. I know that's one of the things we learned in nursing school, but for some reason we often forget. The rectal area can become really irritated and sore and is at risk of a breakdown. which could even lead to infection, either locally in the skin or perirectal abscesses, which are awful for our patients and very painful. So reminding our patients to use mild soap and water after each bowel movement, rinse well and pat dry, don't rub and scrub. A moisture barrier ointment could also be really helpful in protecting that skin from moisture and irritation.
That is a lot of information about diarrhea to make sure we understand.
Yes, it is.
I mean, with that being a dose limiting toxicity for this particular treatment, it is so important. And you mentioned at the beginning of talking about this, just there are so many different potential causes for diarrhea. So it's really important for the nurse who is working with the patient, receiving irinotecan, to kind of put all of those different pieces into perspective and make sure that we are understanding how that is affecting a patient or the cause of the diarrhea. And then, what is going to be the best way to treat, that side effect. So thank you for that really good explanation of how we need to understand and manage that side effect for these folks.
Oh, thank you, Stephanie.
Now let's talk a little bit about irinotecan used in combination. You mentioned at the very beginning when we were talking about the different diagnoses that this treatment is used in, that it is frequently used in combination with other treatments. So talk a little bit about that for us. And then does the fact that it is used in combination change anything that we as nurses administering this need to take into consideration, in administration or in patient management, as far as maybe increasing an adverse event or a side effect that we don't want to happen?
Oh, absolutely. Thanks for bringing that up, because we often do give irinotecan in combinations. And anytime we combine two or more anti-cancer agents, some side effects can be increased. So while irinotecan can cause some oral mucositis on its own, when you combine irinotecan with 5-FU, it appears to increase that risk further. So irinotecan is often administered in combinations with 5-FU, like in the FOLFIRI regimen or FOLFIRINOX regimens. And so patients may be at a higher risk of this oral mucositis, and we need to talk to that patient about how to reduce that risk or prevent it. In some cases, there may have to be a dose modification of the 5-FU drug, even though we're trying to maintain full dose of irinotecan when oral mucositis occurs. One of the evidence-based nursing interventions to prevent oral mucositis with 5-FU is to offer the patients ice chips during the IV administration. The idea is holding ice chips in the mouth that the cold constricts blood vessels and limits the oral mucosal exposure to the 5-FU. So while ice chips are fine for 5-FU and irinotecan combinations, if that regimen also includes oxaliplatin, like in FOLFIRINOX, ice chips are contraindicated then because of the cold-induced laryngeal spasms associated with oxaliplatin. So we have to pay attention to each drug in the regimen when we're looking at, do any of their side effects overlap, and therefore the patient's at an increased risk. And then we also need to double check our nursing interventions, even though they're evidence-based. Are there any contraindications because we're using drugs in combination with each other?
Thank you. That's great. I think it is so important that we understand how to use or how combination therapies are used, whether that's, with other chemotherapies, with immunotherapies, with radiation therapy. There's just so many different ways that our patients have treatment options, but it's just really important for us as clinicians to understand, that whole picture for what that treatment is going to be. So, Rae, can you talk about what are some key resources that nurses can access to learn more about irinotecan infusions and its adverse events?
There's quite a few of them out there. I mean, always the package insert and manufacturer's recommendations are important. Depending on where you work, if you have access to a pharmacist, they can also be very helpful as you're planning your patient's care and doing your pre-treatment assessment before you give a drug like irinotecan. Some of the online resources include, checking national guidelines with the National Cancer Institute or on a reliable website. Of course, Oncology Nursing Society has a great website, and they even have postings of journal articles, guidelines, and those wonderful ONS communities that we were talking about earlier, where members can post questions and guide other members to resources and articles that are evidence-based. Some of the hard publications offered by ONS include the chemotherapy and immunotherapy guidelines, as well as the clinical guide for anti-neoplastic therapy. So those books are on my shelf, and I have to say I use them all the time. While I like online resources, somehow going back to that book on the shelf is one of my preferred things to do. Just make sure that if you do keep hard references like a book, that they are recent and up to date, because our research is rapidly evolving and we want to make sure that you're utilizing the most current information.
In some of our other conversations, you have just had a wealth of information for us, and this has been a great resource for nurses that are listening to the podcast who maybe are new to oncology and haven't administered irinotecan, or it's been a while since they have. So great refresher for folks as well. But as we are getting to the end, I have my 3 rapid fire questions that I would like to ask you before we finish up. So first one is, what are some common misconceptions about irinotecan?
Well, I'm not sure if it's a misconception, but I think it's something that sometimes nurses who are not familiar with irinotecan misunderstand, is the chemo-induced diarrhea. Usually we're not used to talking about early onset and late onset diarrhea. They think all diarrhea is kind of alike. So I think irinotecan is one of those opportunities for us to step back and say, ooh, do I really understand diarrhea like I thought I did? Because there's more than one kind. And especially because that early onset tends to be cholinergic induced, that the treatment may be a little bit different than what we're used to.
And then what is something about irinotecan that's not often discussed, but you wish people knew more about?
Hey, so we talked about the common adverse events or the common side effects that we deal with a lot, like myelosuppression, nausea, vomiting, and diarrhea. But there's a couple of odd ones with irinotecan that the nurse may want to keep in the back of their mind. This is going to sound a little funny, but there are patients who are what they call homozygous for the UGT1A1 allele who have difficulty metabolizing irinotecan. Now, that's a gene in the liver that belongs to a family of genes that provides instructions of how to make certain enzymes that are needed to metabolize or break down drugs like irinotecan. So if the patient has that homogeneous allele or that gene difference, they may not be able to metabolize the irinotecan, which means more of it stays in the bloodstream and can cause increased side effects, especially severe neutropenia. If for some reason a patient has already been identified to have this difference, even the initial dose should be reduced or at least considered by the provider to help prevent serious side effects, including a very severe neutropenia. Another weird thing that isn't common with irinotecan, but you may find in the literature, is there is a risk for interstitial lung disease. It's often abbreviated as ILD. This is a fever, dyspnea, and if you were to do a chest x-ray, they would show what is called reticulonodular pattern on that chest x-ray. There isn't a clear association or causality with irinotecan, but in early clinical trials, they noticed that some patients with pre-existing lung tumors or non-malignant pulmonary disease often developed ILD. So it's something to look out for. If you have a patient with any kind of pulmonary disease, even non-malignant, to be on the lookout for this fever, dyspnea, and that sequela.
So thank you, Rae. Again, it has been a pleasure talking with you again today and just really giving us a lot of good information about this therapy that is frequently used and that nurses are going to probably see at least once in their practice. So do you have any final comments for us today?
Well, Stephanie, thank you again for having me. And I just want to say, hey, I'm glad to have this opportunity just to share a little bit with other oncology nurses. You can do this. Work together as a team. Buddy up with your preceptor or mentor. Don't be afraid to talk to your pharmacist. Talk to your medical oncologist. And don't forget to engage your patient in education and in the assessment. To get working together as a team, we can give Irinotecan safely.
Great. Thank you so much, Rae.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.